Right now, somewhere around 50 million Americans over 65 are managing their blood pressure, taking a pill every morning, cutting back on salt, checking the numbers on that home monitor sitting on the bathroom counter. And the target almost all of them are chasing, the number a doctor gave them years ago and told them to hit, might actually be putting a meaningful number of them at greater risk than the blood pressure they started with. That's not speculation. That's what a growing body of cardiovascular research in adults over 65 has been showing for close to a decade now. And the reason most seniors have never had this explained clearly isn't because their doctors don't care. It's because a 15-minute appointment was never designed to hold a conversation this layered. I'm Dr. Adam. I focus on cardiovascular health and aging, specifically how the circulatory system changes after 60 and what that means for how we read and manage blood pressure in older adults. In my work with people over 65, here's the pattern I keep running into. People who have been faithfully managing their numbers for years, doing exactly what they were told and still feeling off. Tired in a way sleep doesn't fix, dizzy when they stand up, foggy by mid-afternoon. And nobody has ever connected those symptoms to the medication sitting on their kitchen counter every morning. That's what this video is about. Not scare tactics, not telling you to stop your medication. This is about giving you the full picture, the one the research actually supports. So your next conversation with your doctor is a real one. Stick with me because by the end of this, you're going to look at your blood pressure numbers differently than you did 5 minutes ago, and that shift matters. There's a specific kind of tiredness that settles into people past 65 who've been managing a chronic condition for years. Not dramatic, not an emergency room kind of thing. The kind that quietly shrinks your life. The morning walk gets a little shorter. The grandkids' soccer game feels a bit more draining than it used to. The number on the bathroom monitor creeps up slightly, and there's that familiar knot in your stomach. Did I do something wrong? Too much salt yesterday? Should I call the office? But constant vigilance is exhausting on its own. And underneath it, there's often a quiet, rarely spoken suspicion. Maybe the number I was told to hit was never really right for someone my age. That suspicion deserves a real answer. And the answer starts with understanding what blood pressure actually measures, and why the same number means something completely different in a 45-year-old body versus a 70-year-old one. Your blood pressure reading has two numbers. The top number, systolic, measures the pressure in your arteries when your heart contracts and pushes blood out. The bottom number, diastolic, measures the pressure between beats when your heart is resting and refilling. For most of the 20th century, medicine focused mainly on that bottom number, the diastolic. Older textbooks treated an elevated diastolic as the main red flag for cardiovascular danger. Then the research shifted. By the late 1990s, it was clear that in adults over 50, the systolic number, the top one, was actually the stronger predictor of heart attacks, strokes, and heart failure. That shift matters because of what happens to your arteries as you age. Young, healthy arteries are elastic. They flex and absorb the force of each heartbeat the way a rubber hose handles water pressure, expanding slightly with every pulse to smooth things out. Over the decades, those artery walls gradually stiffen. The elastin fibers that give them flexibility break down. Calcium builds up. The vessels go from flexible tubing towards something closer to rigid pipe. That stiffness affects the systolic number directly. When the heart contracts against stiff arteries, there's no elastic give to absorb the impulse, so the pressure spike is sharper and higher. The systolic number climbs. Meanwhile, the diastolic number, the between beats pressure, can stay normal or even drift lower because stiff arteries also lose some ability to hold pressure during that resting phase. The result is a pattern called isolated systolic hypertension, top number high, bottom number normal or low. This isn't rare in older adults, it's actually the dominant form of high blood pressure in people over 65. And it's a fundamentally different condition from the high blood pressure seen in younger adults. Treating it the same way, with the same targets and the same intensity, is where problems start. In 2015, a major government-funded study called the SPRINT trial published results that shook the cardiology world. The study enrolled over 9,300 adults at elevated cardiovascular risk and split them into two groups. One group was managed to a standard systolic target under 140. The other was pushed to an intensive target under 120. The question, does getting that number lower faster actually lead to better outcomes? The headline answer looked like yes. The intensive group had significantly fewer major cardiovascular events, fewer heart attacks, less heart failure. The results were strong enough that the trial was stopped early. Within a year, major cardiology guidelines shifted, pushing the recommended target for most adults down to below 130/80. That's the guideline behind an enormous share of prescriptions written today. Here's what the headlines left out. And this part of the data got a fraction of the coverage. The intensive group, the one pushed under 120, also had significantly higher rates of serious complications. Acute kidney injury was about 50% more common. Dangerous drops in blood sodium and potassium were more frequent. Falls requiring medical attention happened more often. Fainting episodes increased. And when researchers looked specifically at the older, frailer participants, the balance between heart protection benefits and serious harm looked a lot less favorable than it did for younger, healthier people in the trial. The researchers noted this themselves. Follow-up analyses noted it. Geriatric specialists have been pointing this out for years, that the SPRINT results shouldn't be applied the same way to every adult and need to be read with extra caution in older patients, where the cost-benefit math is just different. That nuance never really made it into everyday clinical conversations. What made it through was simply get below 130. And millions of seniors have been living under that target ever since, many experiencing exactly the side effects the data predicted without anyone connecting the dots. Let me tell you about a patient I'll call Walter. Walter was 73, a retired postal worker from Pennsylvania. He'd been managing his blood pressure for about 6 years. Stable, well controlled, no real issues. When the guidelines changed, his doctor adjusted his medication to bring his systolic under 130 per the new recommendation. Walter did everything right, took it exactly as prescribed. Over the next few months, Walter's daughter noticed he seemed slower getting up in the mornings. He mentioned a few times feeling unsteady getting out of his armchair. He chalked it up to age. She did too. At his next checkup, his doctor saw a systolic of 122 and told him his numbers looked excellent. About 6 weeks later, Walter tripped on the edge of his back porch step, fell hard, and broke his wrist. When I reviewed his readings and ran a standing blood pressure test in my office, measuring his pressure sitting, then again within 2 minutes of standing, his systolic dropped 26 points and his diastolic dropped 16 points the moment he stood up. Sitting down, his numbers looked perfectly controlled. But the second gravity made a demand on his circulation his body couldn't keep up. When I adjusted his medication to allow a resting systolic closer to 137, his morning unsteadiness disappeared within about 2 weeks. What he told me when he came back was, "I didn't realize how much I was holding on to furniture every time I stood up. I thought that was just getting old. It wasn't age, it was a target that had never been adjusted for his actual body." What Walter experienced has a clinical name, orthostatic hypotension, and it's one of the most under-recognized blood pressure dangers in older adults. It's defined as a meaningful drop in blood pressure, at least 20 points systolic or 10 points diastolic, within 3 minutes of standing up from sitting or lying down. In younger adults, the body's automatic pressure-correcting reflex kicks in fast enough that this drop barely registers. Maybe a quick head rush that's gone in a second. But in adults over 65, that reflex slows down. Blood vessels respond less efficiently. The nervous system that's supposed to tighten vessels quickly when you stand operates with less precision. And blood pressure medication that lowers your resting numbers makes all of these systems work even harder to compensate, meaning the drop when you stand becomes bigger and lasts longer. This isn't a small thing. Hip fractures in adults over 70 carry a 1-year mortality rate close to 30%. A fall caused by medication isn't a minor footnote, it's a serious event. For someone in their 70s living alone, a fall in the bathroom at 6 a.m. can be the start of a chain reaction that ends independent living. And yet the standard blood pressure reading taken at your appointment, the one your doctor uses to judge how well controlled you are, is taken sitting down after 5 minutes of rest in a calm, climate-controlled room. It captures one single slice of your day. It tells your doctor almost nothing about what happens to your circulation the moment you stand up and walk to the kitchen. Now let's talk about something called the J-curve, because this is at the heart of why how low is too low isn't a fringe question. It's a documented risk. When researchers plot blood pressure against cardiovascular outcomes across large populations, you'd expect a straight line, higher pressure, worse outcomes. And that holds true across the upper range. But the data also consistently shows, especially in older adults, that once blood pressure drops below a certain point, the risk doesn't keep falling. It starts climbing again. The graph forms a J shape, risk high at the top, dropping through the middle, then quietly rising again at the bottom. The most clinically important part of this J-curve for seniors involves the diastolic number, that bottom figure. Multiple large studies have found that diastolic readings below roughly 60 to 65 are linked to a higher risk of cardiovascular events, cognitive decline, and organ damage in older adults. Here's why, and it's worth understanding. Between heartbeats, the phase the diastolic number reflects, is when the coronary arteries, the vessels that feed the heart muscle itself, do most of their refilling. So while your heart is resting and refilling, it's also being resupplied with oxygen-rich blood through those same vessels. If diastolic pressure drops too low, that resupply gets compromised. And in an older adult whose coronary arteries already have some degree of narrowing, which describes most people over 65, a diastolic reading of 58 isn't just a number on a screen. It can represent a quiet, ongoing oxygen shortfall to the heart muscle with every single beat. A major study published in the Journal of the American College of Cardiology found a clear J-curve relationship in elderly hypertensive patients with meaningfully higher cardiovascular risk once diastolic pressure dropped below 60. This research exists. It's not obscure. But the clinical conversation around blood pressure targets in older adults remains almost entirely focused on the top number and says very little about how low the bottom number is being pushed in the process. So what's the right target after 65? That's the question this whole video has been building toward, and I want to give you a real answer. The honest truth is there's no single ideal number for every adult over 65. Anyone who hands you one universal target without knowing your age, your overall functional health, your kidney function, your fall risk, and your specific medications is giving you an oversimplified answer to a complicated question. Here's what the current evidence does support across multiple studies and endorsed by geriatric specialists. For adults between 65 and 75 who are in reasonably good functional health without significant frailty, a systolic target in the 130 to 140 range is generally appropriate. The cardiovascular benefits of tighter control in this group are real, as long as the diastolic number isn't being pushed below 65, and as long as orthostatic drops are being monitored. For adults over 75, especially those managing multiple conditions with any frailty, cognitive concerns, or higher fall risk, a systolic target of 140 to 150 is increasingly supported by geriatric medicine literature as the appropriate individualized goal. This isn't relaxed care, it's precise care. The question for this group isn't whether lower is better in theory, it's whether the specific risks of aggressive treatment for this specific person outweigh the benefits. And for every adult over 65 on blood pressure medication, there's one question that should be part of every medication review, and almost never is. What's your diastolic number running, and what happens to your pressure when you stand up? Here's exactly what I want you to do before your next appointment. Find out what your diastolic pressure has averaged over the past 3 months. If you have a home monitor, check your logs. If not, ask your doctor's office for your recent readings. If that bottom number has been consistently running below 65, that's not something to quietly note. That's something to bring up directly with your doctor and ask whether the medication level producing that number is appropriate for your age and risk profile. If you don't already have one, get a validated upper arm blood pressure monitor, not a wrist monitor, upper arm. Take readings twice a day for 2 weeks, same times each morning and evening. Sit quietly for 5 minutes first, take 2 readings, and record the average. That log is more valuable than any single reading taken in an office. At your next appointment, ask your doctor 2 specific questions. First, what systolic target are they using for you, and why was that chosen for your age and health profile? Second, has your medication ever been evaluated for its effect on your standing blood pressure, not just your seated reading? If you've experienced any dizziness, unsteadiness, or lightheadedness when getting up from a chair or bed, mention it explicitly. Use the term orthostatic hypotension and ask for a standing blood pressure test, seated, then again within 2 minutes of standing. That one simple test can reveal a medication-driven pressure drop that a standard office reading will never catch. And if you're over 75, currently managed to a target below 130 systolic, and you've been dealing with unexplained fatigue, mental fog, or more dizziness than you had a year ago, bring those symptoms directly into the blood pressure conversation. Ask whether the intensity of your current treatment could be playing a role. That's a medically legitimate question backed by current research, and you're entitled to a straight answer. If you start doing this, the home log, checking your diastolic, asking for the standing test, here's what often happens within the first week. Tracking your own readings at home, instead of relying on one number from an office visit, gives you a much clearer, less anxiety-inducing picture of where your pressure actually sits day to day. Most people find it's more variable than they assumed, and less uniformly alarming. By 2 weeks, if you bring that log to your doctor and have the conversation about diastolic numbers and orthostatic testing, you'll likely have a far more specific and useful conversation about your care than you've had in years. And if a medication adjustment is made, the physical changes, less morning grogginess, steadier on your feet, more consistent energy through the afternoon, often show up within 2 to 3 weeks of a thoughtful change. There's one person I want you to think about right now, not friends in general, the specific person in your life. A spouse, a sibling, an adult child managing a parent's care, someone who takes a blood pressure pill every morning, checks a number on a monitor, and has never once been told that the target they were given was based on research that didn't specifically study people their age. That person needs this conversation, and you're now the one who can start it. Here's what I want you to do today. within the next hour before this gets buried under everything else. Pull out your blood pressure monitor, take a reading, sitting down, then stand up, wait 2 minutes, and take a second reading. Write both numbers down. That's it. That's the starting point. Do that every morning for 30 days and bring the log to your next appointment. By the end of 30 days, you'll have something almost no senior walks into a doctor's office with: a real picture of how your blood pressure behaves across positions, across times of day, across what you ate and how you slept. That's the kind of data that turns a 15-minute appointment into a real conversation about your actual health. I read every comment on this channel. Tell me. Drop one of 3 things below. Write "my numbers" if you want to share what your pressure has been running. Write "getting clarity" if you're planning to bring these questions to your next appointment. Or write "overtreated" if something in this video made you wonder whether your current treatment is affecting how you feel day to day. I read as many of these as I can, and every one matters. Next week, I'm covering something that connects directly to everything we talked about today: the specific kidney markers your doctor should be checking if you're on blood pressure medication, and why most standard lab panels completely miss the early warning signs. If you're on medication for your blood pressure, that video could end up mattering even more than this one.